Hi, good afternoon, everyone. Thank you for joining us for our evidence-based mental health Google Hangout today on driving and dementia, a clinical update for mental health professionals. We're joined for this Hangout by Dr. Allan, who's a consultant old age psychiatrist at the Northumberland Tyne and Wear NHS Foundation Trust, who will be presenting her paper. And our discussants today are Nadina Lincoln, who's professor of clinical psychology at the University of Nottingham in the UK, an expert in understanding how to use cognitive testing to make decisions about driving in older adults, and with Rupert and also by Rupert McShane from Oxford, who's a consultant psychiatrist and the Dementia Clinical Network lead at the Oxford Academic Health Science Network. We're also joined by our editor-in-chief, Andrea Cipriani, who's associate professor of psychiatry at the University of Oxford. I'm Michael Ostacher. I'm an associate professor of psychiatry at Stanford University in Stanford, California. Why don't we begin? Just to let everyone know about this hangout, we may have a little audio delay. Dr. Allan's with Dr. Allan's connection, but we'd like to begin with her discussing a bit the paper that she's published in our journal. Why don't you go ahead and begin, Dr. Allan?
Much fortune, and it's great to be joining you here today. So the paper we wrote, Driving and Dementia, and the reason for writing this article and for having a further discussion is I think this can be a really difficult issue for patients. So it's hard when patients come to clinic and they receive a diagnosis of dementia, but I think often people don't realize that that diagnosis often has implications. And here discuss what those implications are about their driving. Is that most people with dementia, especially mild dementia, can actually still drive. So having a diagnosis doesn't automatically exclude people from driving. Driving is a complex task that uses a number of requires visuospatial function, have memory, be able to attend to the road, to have good motor skills, and therefore in somebody with dementia, all these functions can be affected. Possible that people may need to review appropriateness. In addition to cognitive function, people need to obviously find their direction, find their way, be able to stay awake. So there are a number of other factors that can cognition. When I meet people with dementia who are driving and maybe starting to have problems, I think some of the people are variation. It might be in people driving too slowly or too fast for a particular road. Things such as forget a seatbelt on, to potential problems with their driving. Some of the evidence shows that actually caregivers can people may have had offences. They might be driving less than 60 miles a week, and they might be trying to avoid certain situations. So who've got those sorts of risk factors may signpost people. I think a lot of studies have looked at make people safer, for example, by making sure that they use onboard direction finding devices, sat-nav sort of devices, whether they have a caregiver. But there isn't any clear evidence that happens actually when people are driving in a straight line. So careful about sort of driving history and about modifications and how that might or might not be safe that diagnosis. People with the diagnosis of impairment don't have on the DVLA. The question that though is for clinicians. So you might have a person who needs to inform them, but what happens in the meantime, and are they safe to drive? And is it possible to advise people? Is it possible to assess people to sign? With the literature, I think the short answer is that it's very hard for in clinic to actually do a careful assessment of a patient and to be out whether or not they can drive. And single don't actually give information. The evidence shows the holistic assessment, so you need a history from the patient, you need to look at factors which might increase risk related to driving, and you need a history from an informant looking again at risk related to driving. Neuropsychological tests that test cognitive functions, and so at a broad range. A lot of screening has the mini mental state examination or the MOCA, the Montreal Cognitive Assessment, and I think there's a great temptation to try and rely on that sort of screening tool to say, well, you're above or below a certain cutoff, and that means you can't drive. And I certainly would caution people against doing that. I score very poorly on these tests to be drive, but I think for the people who are scoring relatively still doesn't reassure clinicians whether or not they are safe to drive. Testing can't necessarily be a set of assessments for having an on-road every test, and that's something that's done in an assessment centre. It lasts a couple of hours, and it's not just an assessment of driving, it's actually much broader than that. So the assessor, often an occupational therapist, will ask questions to the patient, they'll do some cognitive testing, and then they'll observe driving on a set route, initially on a sort of circuit, and then out on the roads. And they'll make quite detailed comments about either positive points about driving or about points that require a bit of outcomes from. They might advise somebody retains their license, has more regular reviews, or has to give up their life. And people need, they do go to assess that there's a so I mean, a few other things to think about that can signpost people to problems. So any near misses, people consider reviewing. Diagnosis itself might make people review something like a diagnosed dementia, where people's attention fluctuates, where they might get a lot of visual hallucinations, where they may have problems with sleep. Might mean that they'd be less safe on the roads. Vascular dementia and TIAs, again, maybe less safe driving on the roads. For clinicians, they're to balance their patient's interest, and also they need to think their patient. And it's about maintaining autonomy as when to directing if they really believe that there are issues. I think it's also important to recognise that a loss of driving life can have a huge impact on their sense of autonomy and of well-being, and it is something that quite carefully, and a clinician recommending somebody stops driving also needs to have a good discussion whether that's use of public transport, reliance on can travel and be social. that paper may want to add to the questions, we might be able to generate a bit of discussion.
Charlotte, let me ask you, at the top of your screen, turn the camera off, and I think we're having a little bit of audio delay. So as much as I want to be able to see you, I want more to be able to hear you. And so if you can turn the camera off, it may be that we won't have as much audio delay. Are you able to hear us now?
Yes, I can still hear you. Yes.
Okay, good. And I think I think that will be much better for our discussion, since I think the amount of bandwidth you have may make it difficult to have audio and video together. If that doesn't work for you, is there more you would like to finish up? I may have interrupted you.
No, that's fine for now.
Okay. All right. And so for those who don't have the paper, it's available on our website, ebmh.bmj.com. The direct link to it is available through our Twitter feed, and there's a URL listed there for those of you who want to follow along by reading the paper. Nadina, you've done a significant amount of work looking at the specific kind of efforts to see whether or not you can determine whether or not driving safety can be predicted with testing. Would you like to talk a little bit about that?
Yes, I mean, I think that there is now an increasing body of evidence looking at the relationship between cognitive test results and whether people are fit to drive on the road. I think the difficult thing about the literature is there's a lot of conflicting evidence, but that's because most of the analyses have looked at individual tests, and it is not likely that one cognitive domain is going to be predictive of whether somebody is fit to drive. And so what is needed is batteries of cognitive tests that tap into all the relevant cognitive domains. And people now are increasingly trying to develop batteries that are specifically related to assessing fitness to drive. The batteries have moderate predictive validity. I think the estimates range between about sort of 70% and 90%. And I suppose my concern is that they've been quite heavily criticised as not being accurate enough to be used. However, at least for the cognitive test batteries, we have some indication of their predictive validity, whereas many other aspects of the clinical assessment, we have very little information on their predictive validity. I think the other point is that cognitive tests were never intended to be used on their own in isolation, but in conjunction with other aspects. So, for example, we've looked at one particular cognitive test battery to see if we can predict whether people are safe to drive, and the predictive validity comes out at about 70% or so, I think, in repeat studies. But if you look at the misclassifications, often there is clinical information in those misclassifications that explains why the cognitive test couldn't actually come up with all the results. So, for example, we know that people with high-level driving skills before the onset of their dementia are more resistant in terms of their driving to the cognitive decline. So in our studies, we had a police driving instructor, for example, who was training police to drive police cars fast, very skilled driver. And although the cognitive test predicted he would be unsafe on the road, he was actually quite safe. And that's come up in other studies that professional drivers tend to do better. Similarly, we've had people who we've predicted would be safe to drive, but they've been found to be unsafe. One particular example I can think of is that we assessed somebody with a manual transmission car because that's what he arrived at the with, and it turned out that actually most of the time he drove an automatic car. And the comment from the driving assessor was, well, if he'd been in an automatic, he would have been fine. It's just that he kept on looking at the gears and not concentrating on the road. So right. I think there is a limitation to, the research is done in a way that's fairly constrained and doesn't include consideration of clinical factors, and that the combination of cognitive and clinical factors can be useful. I think my final point relates to the purpose of cognitive tests, often the cognitive tests not to make the decision about fitness to drive, but to identify those people who need an on-road assessment. So for an example, there's a test called the Rookwood driving battery, which is not mentioned in this review because it's based on a mixed etiology sample, but that has good, it is good at identifying those people who are unsafe. So if people fail on the Rookwood, they're highly likely to fail on the road, but it's not that sensitive. There are lots of safe drivers who will also, there are, in terms of the sensitivity, it will not pick up all the unsafe drivers. On the other hand, there's what's called the dementia driver screening assessment that's good at predicting safe drivers, and it misses some of the unsafe ones. But if we can screen out, say, the safe drivers, so make a recommendation that those people would be fit to drive, and then send those who don't pass the assessment for on-road assessment, then we will have a more efficient system. So I think it's about using a combination of cognitive tests in conjunction with on-road assessment for those people who need it. We haven't got the resources to assess everybody on the road. If all those people with dementia who wish to continue driving went to the specialist driving assessment centres, they simply wouldn't be able to cope. So it's actually about using cognitive tests to identify those people for whom it's most appropriate. So I think cognitive tests had a role, and that perhaps I feel they have more of a role than has been recognised.
Charlotte, would you like to comment about that?
I think it's a really helpful comment about using cognitive tests to assess who should go for a driving assessment on road, because I think certainly we're seeing increasing numbers of people who are being diagnosed, especially in the early stages of dementia, and I entirely agree that it's not appropriate for all those people to have on-road driving tests, and it's just about knowing who we should be gathering further information about. So I think using cognitive tests in that way might be helpful. I know that Dr. McShane has also been trialling some other ways of trying to assess in the clinic who might require further assessment, and I wonder if it's a good point for him to as well.
That's great. Rupert, do you have a comment?
Sure. Yeah, I mean, I'd just like to say how much I agree with absolutely everything that Nadina and Charlotte have said. I think it's spot on to be thinking about cognitive tests as essentially a form of decision aid, and as part of an algorithm that leads one either to assess that somebody's safe to drive, not safe to drive, or needs an on-road assessment. So a sort of traffic light system has it has clinical sort of makes sense. So I agree with Nadina that we shouldn't be throwing the baby out with the bathwater as far as cognitive tests goes, and also that a battery of tests is necessary. I think that one of the other things, just to comment on the type of tests, although not in any great detail, is to say that I think that obviously driving involves reaction times, and it's therefore necessary that I would imagine that the predictive the tests that are likely to have the highest predictive value, a battery that is likely to need to include tests that have a reaction time component and have a component of timed split attention in them. But all that remains to be pursued with serial sort of bits of research and comparing different batteries. So, and I also agree very much with Nadina's point about on-road testing and the difficulty of suggesting that everybody goes to on-road testing. I think even if we start to really use cognitive testing in a routine sort of fashion, and that's certainly not happening in the UK yet, although I think probably it ought to be happening, that it's quite likely that that would result in a very large increase in the number of people going for on-road assessments. And in the UK at the moment, just to give you an idea of the costs involved here, an on-road assessment is currently subsidised by about £300 or £400, in addition to the costs that the drivers typically bear of about somewhere between £70 and £100. Whereas a cognitive test battery is also going to have costs attached to it, particularly if, as is likely to be the case, it involves bringing the patient back for a second appointment. So a key issue is really at what point in the patient's pathway or follow-up are we thinking about having this assessment. For what it's worth, just if I'm seeing somebody in a memory clinic for a first assessment, I'm pushed to get through it all in an hour and a quarter. If I was then going to be adding on top of that half an hour's assessment using a cognitive paper and pencil cognitive test or a computerized cognitive battery, or indeed going through a sort of formal assessment procedure such as the Rookwood, that's going to make it a very long appointment. And one of the things that deters people from coming forward for assessment and diagnosis is in fact the fear that they'll be stopped from driving. So I think the whole issue needs to be raised in a paced way that's appropriate to the patient. On the other hand, it's possible that people that as GPs increasingly take on the role of diagnosing people with dementia, that they will want to refer people directly for a separate driving assessment so that they can get some sort of measure of some sort of rational measure that will help them to feel that will assist them in their decisions. So just a couple of other points that I wanted to make. One is that I think that the issue about the positive and negative predictive value that Nadine was talking about is very important, and that commonly the problem that we get with people who might be safe to drive, who are stopping from driving, I think probably affects women more than men. But so there's a big dropout in the UK. What happens is that at the age of 70, you have to reapply for your license and just sign to say that you're healthy. And at that point, there's a very large dropout in the number of women who stop. There's a very large number of women, particularly, who stop driving. And that may or may not be because they're making a sensible decision. So maybe that in fact the women are less safe to drive. They've had maybe got fewer miles under their belts. So there are lots of different aspects to it. So that's just one issue. And the other issue to talk about is just about the issue of longitudinal tracking in a progressive illness. So I know that some of the on-road driving centres are particularly exercised by the potential for, if they're doing serial on-road assessments every 6 months, just as with us in our follow-up clinics, they fill up pretty quickly, and so that whole business of tracking when somebody who's initially unsafe has become who is initially safe has become unsafe, right, is a really is something that we need to grapple with. And the thing that I'm interested in, that Charlotte alluded to, and she made it sound that I got much further with it than I have really, is the idea of using telematics to see whether you could develop a signature that predicted unsafe driving in the elderly. So we know that insurance companies obviously use telematics to try and predict unsafe driving or to predict accidents in young people, and so the algorithms typically involve driving fast at 3 o'clock in the morning and braking suddenly. These are very easy things for a black box to pick up using an accelerometer and GPS and so forth.
So tell us what you mean by telematics.
The telematics is I'm sorry if I've jumped ahead here. Telematics is where you put in a black box in a car that's got an accelerometer and GPS, and it'll send the data to an insurance company, who will say, your pattern of driving makes you unsafe, and they'll either stop you from driving or they'll hike the premium. So it's often a condition of 17 and 18-year-old drivers that certainly in the UK, and I imagine it's the same in the States, that if they're to get any sort of insurance for driving, that they have to have one of these black boxes. The problem of applying that technology to the elderly is that, by and large, unsafe older drivers are not characterised by driving at 3 o'clock in the morning and going much too fast. Right. They tend to be dithery, right. Have trouble with right-hand turns. In America, it would be left-hand turns across traffic. And they tend to be very poor at merging onto into fast-moving traffic, so coming off a slip road and onto a major road. Those are the key things that older drivers have trouble with, and those are the more easily identifiable things that older drivers have trouble with. But whether you can pick that up using the same telematics technology that is used for younger drivers is an entirely open question at the moment. But you can see that might be attractive as a way of helping drivers to self-regulate, right? So that they're sort of deciding for themselves when to stop driving on the basis of information that they've got from the telematics, rather than getting the telematics.
It seems as if those algorithms could be developed, that would be useful. Just off the top, seeing whether people exceed the speed limit or brake quickly is much easier to determine than whether or not somebody is driving on the wrong side of the road, making inappropriate turns. It seems much more difficult to do. I'm out here in California in the USA. Our driving laws are state-based, not national, for the most part. But there are similarities to what the DVLA requires, which is reapplication for driver's license at age 70. In California, it only requires a written examination and a vision test. But what California does do is require that, in order for somebody to know that they have, for the Department of Motor Vehicles here, the DMV, to know that somebody has dementia, they have to be reported as having dementia. And it seems that the needle that needs to be threaded is very similar here as in the UK, which is moderate to severe dementia in and of itself in California is a reason for people to have their license revoked. And so the determination of moderate to severe dementia seems fairly straightforward. It seems from Charlotte's paper that that's the case in the UK. Also, that people with moderate to severe dementia are not expected to be able to drive. So really, this concerns people with what used to be called mild cognitive impairment, or with mild dementia. Is that the case? And if that is the case, how does the testing differ how would the testing and what the predictive value of the testing, how would it differ for people, for instance, who have early dementias, mild dementia, versus those whose dementias are more advanced?
I mean, I think a lot of the predictive validity studies have been on people with mild and early dementia. I mean, certainly the studies we've done looking at cognitive testing has recruited people from memory clinics, and it's usually at the point of diagnosis when the discussion starts to happen about driving, and a lot of the studies haven't included people at the later stages because, in a sense, that's not where the question is.
Right.
The other point you might,
Charlotte.
Okay, is I think it's about providing information to patients as well. So I think to reassure people that they're performing well on some domains, if they're worried about the driving, or also if they haven't got very good insight into potential problems, then the cognitive testing in the clinic can be quite a good way of trying to increase people's insight and trying to explain that there are certain problems with certain domains and how that might affect driving, and that might help people to make their own decisions.
I think the other advantage of having cognitive assessment as something separate is that when people are found to be unlikely to be safe to drive, it becomes the person who's administering the test who is the the person who's making that recommendation, and they are slightly separate from the clinician who's trying to discuss it in a more positive light. So in a sense, the blame can be put on the cognitive assessor.
Yes.
That's really important, I think, and that's one of the reasons why primary care physicians referred into secondary care is to get somebody else to take the flak.
Yes.
If I was able to divert the flak again to somebody else, that would be just terrific.
So from a simplistic perspective, is there an easy test for determining whether or not somebody's dementia in and of itself is severe enough to require by law that their driving be restricted? Or is that's not codified in any way?
Well, I would disagree with what you said earlier, which was the notion that somehow, if you can distinguish between somebody having mild and moderate dementia, that would be sufficient as a basis for making a determination about whether they're safe to drive, because that determination would necessarily sit on a cognitive score. There will be people who have moderate dementia who are certainly safe to drive. Not very many of them, but there certainly will be, and that's so I think that just having it based on the severity of the dementia is it's certainly a step forward. I wouldn't want to say that was a completely useless way of doing it, but I think that having something that has more face validity and is directly relevant to the driving process itself it can sometimes be slightly easier for the patient to swallow. Whether a cognitive battery would fit that bill as having that sort of validity in the patient's eyes is a moot point, because often they're absolutely certain that they're safe to drive, even when the family is saying, certainly not let my kids in the car with them.
Right. Well, it's interesting because somebody wrote this law in California, which
it's not a bad start.
Well, yeah, which is we have about 14% of the U.S. population here, so it's a pretty big state. Reexamination is only appropriate for drivers whose dementia is still diagnosed as mild. Drivers with a medical diagnosis of moderate severe dementia need no further testing, because progression of the disease beyond the mild stage of dementia renders the person unsafe to drive. So I don't know how much, we must be much brighter out here in California to be able to make that easy determination, I think. But it seems as if the cutoff between mild and moderate dementia is not so bright, right?
Yeah, I think.
Go ahead, Charlotte.
Okay, the simple answer to your question, is there a certain cognitive cutoff which gives advice about driving? I mean, the answer is no. I think there's no test which actually reliably does that in a way that's totally applicable to driving. But I think certainly one study did say that people with an MMSE score of less than or equal to 24 and people with a MOCA score of less than 18, that should certainly raise alarm bells about their driving capabilities, and they're unlikely to be safe to drive. But there's certainly nothing categorical in relation to any cognitive test scores and driving safety.
Right.
Well, I mean, I'm not sure that that's the case. I mean, there are some tests that have cutoff scores that can be used and that have been validated in relation to on-road assessment. I think the problem is that each study has been conducted in an independent sample, and what we haven't got is the replication studies applying those criteria, and again, to make sure they hold up in different settings. So there are studies that give quite strong recommendations about cutoffs. It's just that they need replicating, and we also need to know how much better the whole process is if you include the cognitive assessment as compared with not doing so. So I think it's a bit, it comes back to throwing out the baby with the bathwater. There are batteries that give recommendations. They're not 100%, but I think it'd be better if people use them rather than just saying, oh, well, there's not a clear cutoff point.
And sorry, may I ask who is funding this kind of studies? Is it the government? Is it insurance companies? This kind of study to monitor and assess patients with dementia for driving purposes?
Yeah, a lot of them are charity funded. The problem is that driving sort of falls between health and between transport, and the sort of transport funding says, well, drivers with dementia are not a major concern. We're more concerned about drunk driving, and the health people say, well, it's not a major issue in health research, it should be somebody else's. So it sort of falls between the two, and I think most of the studies have been funded from organisations such as the Alzheimer's Society to try and improve the assessment process.
And when you have a patient with high dementia, or could be moderate dementia, how do you decide? Is there any criteria to decide how often or when to see him or her again? Is it a case-by-case decision? Is there any guidance?
Well, to be honest with you, I think it's not very often that the driving would determine the frequency with which you see the patient. So our own practice is that we will, if somebody with mild cognitive impairment turns up, we'll see them in not less than a year. So it might be 6 months, it might be somewhere between 6 months and a year, but places will vary. If you've got somebody where you're really worried about the driving, you want to try and progress that, then of course you might see them again. You might try and bring the relatives back. So it can be a bit part of a process, although of course the law likes a very binary sort of decision-making algorithm. So when it comes to, if we were to develop cognitive tests that were better predictors of being unsafe to drive, it's a complete unknown at the moment as to how often one ought to be bringing people back to reassess them. That's my understanding. Nadina may have a...
Yeah, yes, there's been very little consideration about, how often you need to repeat. I think the other point is that we are making recommendations to the DVLA, and the DVLA make the decision. I don't know how much, exactly the extent to which the DVLA follow the judgment of the people who are sending them information.
Yeah, what do you expect that they do?
Well, there are certainly some impressions that we've sent fairly concrete recommendations on the basis of assessment. We don't think this person would be fit to drive, and yet they have been allowed to drive. So there's some disparity there.
Yeah. I mean, I think in some ways you're being quite open about the limitations of the research, especially since much of it is your own. But what this concerns really the people at the margins, right? Somebody like this, where you give a very concrete recommendation that somebody should not be driving, but the DVLA decides that they're getting some information from somebody, because it doesn't seem like it's in their interest to keep people on the road who are significantly at risk.
No, I think probably it comes down to the concern that about the predictive validity of the assessments, and that it's not good enough, and they would rather take other information.
Right.
So on the form in the UK, for example, I mean, it's quite interesting just looking at it, because it's the frequency with which the forms are revised in the light of a sort of developing language and understandings of this issue isn't very. It doesn't get the forms don't get revised very frequently. And one of the questions is about does this person have any functional disability? Well, this is the problem that we have in determining the difference between MCI and dementia, and it's not really going to be a very discriminating question. And in fact, the extent to which questions on this sort of form can be discriminating is pretty low. And I think that's why it's important. That's why people want to have a more rational, numerical, validated set of criteria that could be used, because the level of clinical judgment required is really too high, I think.
Yeah, I mean, Charlotte, one of the interesting parts of your paper is when you discuss what the impact of loss of driving might have on patients in terms of their overall health or their mental health and their psychosocial functioning. Would you care to comment a bit about this? Because I think that's one of the, I mean, this is why this is important. One is we want to protect people from the dangers of having people on the road who are not safe to be operating a motor vehicle. On the other hand, we want to make sure that we're not negatively impacting people's lives unnecessarily. And I think one of the points that you make, which is quite pertinent both here in the United States and in Britain, is that rural drivers, or rather people in less populated areas, don't have access to the kind of mass transportation or even access to help that they might have. And so removing their driving ability or their licensure to drive would have a big impact on their lives. Would you care to comment a bit about that?
Yeah, sure. I think it's a really, really important point. To drive is actually almost an everyday part of life for so many people. And I think a lot of people of all ages really rely on their cars for convenience and for just doing activities of sort of their daily life. And I think that's even more so for older people who might have mobility problems, who might not be able to walk and be able to carry things a long way, and may really rely on their cars to get their shopping, to socialize. And that's very important in terms of thinking of health as a very broad concept in terms of their ability to access services, to get to hospitals, to get to the supermarket, to see friends, and to maintain their social contacts, which is so important to living a sort of a rounded and good life. So I think that there's a twofold challenge then, is one about if you are not able to drive suddenly, how do you develop coping strategies to compensate for that? And obviously people with dementia who might have cognitive problems, it isn't an ideal time in your life to actually have to start to learn about which bus you need to get and where you need to get off if you want to still keep seeing your friends. So I think on a practical level, it can be difficult for people to develop alternative strategies, and they may then become much more reliant on carers. When people may be feeling that their independence is under threat and that their autonomy is under threat if they've got a diagnosis of dementia, that removal of a driving license can have quite a profound psychological impact for them. And the other point is about the impact on carers, because a lot of the times I see older couples and maybe one of them drives and the other doesn't. And if it's the person with dementia who does all the driving and who then can't drive, then it might mean that both people are then not able to have easy transport, and that can be quite hard. Sometimes when I speak to people, I'm sort of saying, well, if you're not running a car, you've probably got quite a lot of spare money that you could use to pay for taxis. And I think certainly some people do have an increased reliance on taxis to give them some sort of freedom and to engage in some of the activities they want to do. But I think that also comes with a certain element of anxiety for people, and it's just not the same as having a car parked on your drive and being able to jump in and go where you want and come back when you want. And that I think even using taxis for people, having to make that phone call, wait around, get somewhere, make a phone call and reorganize that sort of task, which requires some executive function and sort of knowledge of taxi firms and companies, can also be difficult for people.
Right.
So there isn't an ideal solution, and certainly there's much more that we could do in terms of improving public transport that might help, but probably people need to start doing that a little bit before some of the a major degree of cognitive impairment sets in.
Rupert, you?
Well, I was interested to know if Nadina had any comments on that. You know, sort of solutions really, because it's I really struggle with this. I've tended to find that it's I've got better at working out ways of encouraging people to stop driving, and the one that seems to work best is to explain that if they do drive, they won't be insured, and that if somebody drives into the back of them and it's not their fault, that then they're still uninsured because they've got an undeclared health problem, and that seems to hit home quite well. But short of Uber dominance and driverless cars, I don't really have an immediate solution, really.
Yes, I mean, I think, yes, when people get to the point where they're clearly unsafe to drive, then it ends up coming, you know, that the threat of not being insured is a major lever to try and stop. I suppose the key thing is if the assessment procedure or the whole assessment process begins relatively early on, and hopefully the first few times people are assessed, they're actually found safe to drive. And at that time, the opportunity to say, well, okay, you're safe at the moment, but your abilities will decline, and to start people thinking about how they're going to cope in the future while they are still driving, so that it doesn't come such as a shock when they get to the point where they're advised to stop.
And I think that speaks to the issue that I raised earlier about when the assessment occurs. Does it occur in the same appointment as, you know, when you make the initial assessment? And I think what Nadine has sort of, I think I completely agree with you that you know, in a way, getting somebody to stop driving is a process rather than an immediate one-off. But you have to be seeing them frequently enough for that to be a realistic possibility.
Yeah, I mean, I suppose that given that people have their licenses reviewed on a regular basis, that would be the time at which there should be some mechanism for saying, okay, is further more detailed assessment needed?
Right. For instance, here.
One thing we're seeing is that because much earlier, and we're giving diagnoses of dementia earlier than we ever used to, we're not providing that ongoing follow-up, and the ongoing follow-up is done in primary care. Final decision, that final conversation is often being passed on to primary care specialists who are then having to make that final decision. So I think anything we can do in secondary care to try and sort of warn people that this might be an ongoing consequence is probably helpful for them.
And that would be an argument for a cognitive test service that primary care could refer into.
So I have a question for all the three experts. I mean, is there any difference in terms of your approach if you have a patient with dementia or patient with stroke or patient with brain injury for the licensing and driving purposes?
Well, I think the issues are broadly the same. You know, about how it is to do the physical manifestations and the cognitive, and of course the on-road. I think if I had somebody with a stroke, then I'd be slightly more inclined to send them to the on-road assessor people earlier, because they haven't got a progressive illness, and it may be that adaptations in the car would help them to drive. And certainly, you know, obviously there's quite a wide variety of adaptations that can be made to cars that make them easier to drive without feet control, for example, or whatever. So, but I think the
evidence base for the assessment procedures used in stroke is a bit stronger. There are far more studies, and there's now been meta-analyses in relation to driving, which actually come out with specific recommendations in the National Clinical Guidelines for Stroke. In contrast, in people with multiple sclerosis or people with traumatic brain injury, the evidence base is even less, I think, than it is for people with dementia. So it's very variable how much information we have.
What do you think leads to that? I mean, not aside from, you know, sample size and you know, how well designed the studies are, is it the case, for instance, that in stroke the deficits are more stable over time, and that with dementia, depending on the context, whether it's anxiety or unfamiliarity, that people's performance on testing changes from test to test?
I think it's that there has to be an assessment for people with stroke. Certainly if they've got a significant level of disability, there has to be some assessment process to enable them to get back in a car. Whereas in dementia, people are currently driving, and it requires somebody to pick up the fact that maybe they shouldn't be before it gets noticed. And I think that's why it's much easier doing the research on people with stroke, because they will come through the system to be assessed.
Rupert, we have just a few minutes left. Is there a case you had thought of that you might want to talk about in which some of the issues that we've discussed today might come up?
Well, I could, just tell you a sort of archetypal case that one might see in clinic. I've got two cases. The first is a reminder of why we're doing this, and that was that this is a true story that one of my colleagues, her nephew was killed by a driver with dementia. So this is a real issue, and I mean it's an obvious thing to say. But it reminds me to just mention the issue that driver safety is slightly different from having had an accident. So obviously the issue that insurers are interested in is has the patient had an accident, but the issue that we in the health service face is we are more conservative in a sense, because obviously there are plenty of people that are unsafe to drive that don't have accidents.
Right.
So anyway, that's the first one. But just thinking about a man who as part of his work used to drive. He has an MMSE of 18. He's quite clearly not frail, and he's quite adamant that he's very safe to drive. And there I am sitting in the clinic, this chap who looks, apart from his cognitive function, to all intents and purposes like you and me sitting here, very difficult to tell him that he's not safe to drive. And then you have this difficult decision about whether to say you're not safe to drive and you cannot drive until you have had an on-road assessment. Then this is the sort of thing that one has to grapple with a bit. And although it is the job of the DVLA to tell people that they can't drive, that sort of slightly fudges the issue. That if you think there's somebody sitting in front of you who isn't safe to drive, and they have then it's your duty really to tell them there and then, and to tell them to stop driving. So I told this chap he needed to stop driving, and he was extremely upset by it. But then he had a test with the on-road assessment people, and much to my surprise, they thought that he wasn't safe to drive. Now, I have a feeling that part of the reason that they thought that was because they did a cognitive test before they took him out on the road.
I see.
So they approached, and he had some language problem, which made it very evident that he had a cognitive impairment. But in terms of handling the vehicle and interpreting the signs, I'm not sure how bad he was at that. No, I'm just genuinely not sure. And the reason I send him off for an on-road assessment is to take their judgment. So that was very helpful, and his family are happy with that judgment. But every time he comes back to clinic, it is the only thing that he wants to talk about.
Right.
For his life, just as Charlotte was pointing out, it is a devastating, traumatic thing that is far more important than the diagnosis of dementia. Really, the latter just pales into insignificance compared to the damage that it causes him. So. I agree with Nadine's assessment of of how funders look at this and the difficulty of falling between two stools. But I do think that the generic health-related funders simply underestimate and they don't see this as bigger issue as it really is. I would say that, wouldn't I? We're in the front line on this.
Yeah, I think that the point that you bring up is, this case is really sort of encapsulates some of the issues that we've discussed, because it's not. You would think that it was how well somebody is able to drive or perform in a monitored testing situation that would determine whether or not they're safe. But that testing situation is only a small slice of time, and it doesn't explain what might happen if they are in a different situation that requires managing more inputs, gets caught in traffic, somebody else cuts them off, something difficult happens. And so it really points to the point of the interplay between this predictive testing with its limitations being added to on-road driving testing that can help people make a decision. And so the example that you gave is really quite brilliant of your being quite concerned that somebody not be able to drive, probably the testing itself being not so bad on the road, but the examiner recognizing that there's a cognitive problem that would require their removal of their license. And so I think that's a very useful example. Charlotte or Nadina, do you have a point to make before we finish up?
No, just thank you, Rupert. No, it was helpful to hear those cases, and I think it does put into context some of the things we've been talking about.
That's great. Nadina?
No, nothing further to add. I think it's, you know, the scope for lots more research. We've probably got as many questions that we need to answer to keep us going for many years. Yes.
Well, as we stop, I'd like to thank again Dr. Charlotte Allan for her terrific paper, Nadina Lincoln for being willing to join us in this discussion with her the great work that she's done, and also Rupert McShane from Oxford, a consultant psychiatrist there with expertise in old age psychiatry. Again, I'm Michael Ostacher, joined by Andrea Cipriani. I'd like to thank our team behind the scenes, and thank you for joining us. This will be archived on YouTube, as it is after each of our Hangouts, and please look to our website and to our Twitter feed to find out when our next Hangout will be. Thank you very much, everyone, for joining.